Welcome back to the Beyond Your Diagnosis series, part 2, Shin Splints. I'm telling you why this is a BS diagnosis and what you can actually do about it, where the pain is actually coming from. So first of all, Shin Splints is just an umbrella term, often used for pain in your shin, that is typically diagnosed in runners, jumpers, military populations. Typically, I'm using that word a lot, it's exercise-induced pain along your tibia, your shin, the front of it, that is most commonly in the lower medial, like 2/3 of the shin. Historically, it's been blamed on the lower leg muscles, the tibialis posterior, the tibialis anterior, and the soleus. It's blamed on those muscles pulling on the bone, but is now understood as more of a bone stress reaction. So now the issue with this diagnosis is that it is really difficult to determine the difference between true shin splints, which is microfractures in the bone, and soreness in the muscles on the front of the bone, like the tibialis anterior. So there's, again, no gold standard test to definitively diagnose unless you're up for an MRI, which in my opinion would just be so silly for something so trivial and harmless. If it is true microfractures, then if overload continues unchecked, shin splints can progress to stress fractures. So I'm gonna give you in this video some exercises that you could do that will help whether you have true shin splints or if it's soreness in the anterior tibialis or tibialis anterior muscle. But here are some red flags to look out for, that if you're experiencing these, I would recommend not doing these exercises and actually going and getting checked, because these could be signs that you do have a true bone stress injury, which need a little bit more attention and monitoring by a professional. So if you're having pain with activity that lingers after stopping, so like soreness in the anterior shin will only present when you're loaded, when you're like walking, running, jumping, things like that. But if it's a bone stress injury, you will still have pain at rest, you will have pain at night. If you do have any kind of history of risk factors like REDS, which was historically known as the female athlete triad. Now REDS is relative energy deficiency syndrome. If you have low vitamin D or poor recovery, those things are cause for concern that there's maybe more going on in the bone, or any more like focal pain. So if you can literally point to it and be like, it's right here, that is more correlated with a bone stress injury than with muscle soreness or even a shin splint, where there is those true microfractures, because those are going to be more diffuse pain. My concern with this diagnosis of shin splints is that it creates fear, because it makes clients believe that they have a fragile bone problem and should avoid loading the area, when the reality is there's no gold standard test to confirm this. And in many cases, the pain isn't from the bone at all, but it's from the muscular overload, which responds really well to progressive safe loading. So where this pain in your shin typically comes from is a rapid increase in mileage, intensity, or terrain change. AKA you got excited and you did a little too much too soon. Also overpronation at the foot and a lower foot arch could lead to more eccentric loading at the muscles that attach to the shin, which now can lead to increased soreness. And then also limited ankle mobility, specifically into dorsiflexion, can increase load on the tibia and the muscles that attach to it, and weakness in the hip abductors as well, or the glutes, can increase load on the tibia and muscles that attach to it. So shin splints are not an actual diagnosis. It's more of a warning light. Like, hey, you have some pain along the shin. when your training load is more than your bone and muscle can handle right now. So what we need to do is increase the strength in the bone and the muscle. And the way that we do that is through load. Because the other thing that comes with any kind of bone injury, even if there is microfractures in the bone, we still need to load the bone. And I think what happens is this diagnosis of shin splints instills fear that we can't load the bone. But Wolff's Law tells us that when we place load on a bone, it actually grows, just like a muscle does. So that's what we're going to do today. I have 3 exercises for you, just like I did for the SI joint. I'm going to walk you through each of them, give you parameters for how often to do them and how many sets, reps, etc. And pain guidelines are going to be the same, 3 to 4 out of 10. We want to push into a little bit of discomfort. We don't want to be fully comfortable, but we also don't want to push past the pain where we're causing more damage. Okay, so the first thing we can do is an ankle distraction to help to open up ankle dorsiflexion. So you just need a resistance band. You're going to tie it around something stable, and you're going to put it on your tibia. A big mistake I see a lot of PTs and patients make is putting the band on the foot. That's not going to do anything. We want to put it on the tibia because this is how your foot acts. This is your foot, this is your tibia, right? So the tibia needs to glide over the foot to get into dorsiflexion, which this is ankle dorsiflexion. Plantar flexion, dorsiflexion. So if we put the band on the foot, we're not helping the tibia glide, right? The foot's already stable. So you're going to put the band around, I'm going to switch feet so that you can see this better. You're going to put the band around the tibia, okay? It's a little bit of an awkward angle. I guess it doesn't really matter which way I did it. Oh wait, I can do this way. Okay. And then what you're going to do, keeping the foot stable, you are just going to gently press your knee over your toes. Again, as far as feels comfortable for you. If you feel more of a pinching in the front here, this is going to be a really great exercise for you. So what I also want you to think about when we're doing this is I don't want you to rotate your hips in or out to get more range. We want it to purely be ankle. So we're just rocking forward and backward, okay? And we want to keep the heel down. The heel coming up defeats the purpose of the exercise. Now, if you're doing this or even without the band, you try this and you feel more of a restriction in the back, then this might not be as effective of an exercise. So what you'd want to do more so is roll out the calf muscles and do more eccentric loading at the calf. What that could look like, I have a step here. I'll come over and show you. So you foam rolled, you increased range of the muscle. Foam rolling, quick side note on foam rolling because I have to. Foam rolling in and of itself, not super helpful long term. Foam rolling gives you short term increases in range of motion. Now, what that does is allows you to train with more range of motion. That's why I like foam rolling prior to a session, not after, and not really on its own, unless you're really just chasing temporary relief. So I would foam roll the calves 30 to 60 seconds. You don't have to do more than that. And then go into eccentric calf raises. And I would do one leg at a time to prevent compensation. So you can pull yourself up and then just count 1, 2, 3, 4. Come up with 2, down with 1. And that's going to help to now lengthen the muscles in the back of the ankle to help increase that dorsiflexion range of motion. Next, what we want to do, we talked about overpronation at the foot. So we can do a short foot exercise to help strengthen our arch, which will help with a lower arch height, okay? So You could also do the supination pronation exercise that we did in the SI joint dysfunction video. Or you could just take your foot, and all we're gonna do here is we're gonna practice flattening and creating an arch. Flatten, create an arch. And all I'm thinking about is pulling this part of my foot back toward my heel. Here. Here. Okay? The last exercise I really like, and I've realized I don't even have a loop resistance band at home. I need to get one for postpartum. But you would take a loop resistance band, like one of those small ones. They call them the booty bands that typically you'd put around your knees when you're doing like glute bridges or whatever with hip abduction. You're gonna actually put it around your feet, okay? So you'll have a resistance band around your feet. You are going to get into a squat and push out. Lateral band walks. What I don't wanna see is this. Why? Because now we're not working the hip as much as we can. So we want to make sure we're leading with the hip. Feet should stay pointing forward, and we're pushing out with the hip. That's going to help strengthen your glute med and your foot muscles as well. A bonus exercise I really like for this one, because if the pain is because the shin muscles, the anterior tibialis, is weak and sore, we need to strengthen that muscle, right? And a lot of people miss this one. So you could simply just lean on a wall and just raise your toes. Okay? So, parameters for everything. For the ankle dorsiflexion distraction, you could do 60 seconds each side, 4 to 5 sets. If you're feeling it more in the back of the calf and you're gonna do eccentric calf raises, 12 to 15 reps each side. Go up with 2 feet, down with 1, 3 to 4 second eccentric. And you're gonna do that 3 to 4 sets. Then for the short foot exercise, or short arc, where we're practicing raising the arches, I would dose it the same as the supination pronation exercise from the SI joint video. So we're gonna do 60 seconds each foot, 4 to 5 sets. And then the lateral band walks, I would do 15 reps each side, 3 to 4 sets. And then for the tib raises, if you're gonna dose those in too, I would do 15 to 20 reps, 3 sets. Again, 3 times per week, keeping the pain threshold 3 to 4 out of 10. And as always, we gotta make sure recovery stays good. Hydration, nutrition, sleep. See you in the next one.